So we are recording for our entry-level program 1/20/2021, and Luke has an announcement.
Okay. So for the Massage Green Spa downtown Lapeer, right next to the school, that location, if you guys want to pop in and get work done, so that as I was saying, learning how to be a massage therapist, it behooves you to go and get massage and experience what it's like to be the client. I am gifting each of you your first session at no cost. And then after that, it will be a $50 flat rate on the hour. So then the normal upgrade, let's say you were paying out of pocket and you want to do a 90-minute, it would be 70. So it's like 20 bucks more on the half hour over and above that initial hour. But $50 on the 1 hour massage, $10 on the infrared saunas. If we had the facials going on, those would be available too. But while we're wearing masks, that's just not possible right now. So massages, saunas, discounted. Do it. It's good for you. But to reiterate, text me directly, your name and number spelled correctly, so I can make a profile for you and notate it so that all of that's in there and I don't have to go and explain it to everybody at the spa. If I can just make your profile and put the note in there, it'll be fixed and taken care of, and you guys can just call and schedule whenever you want or can, and it'll all just be set up for you. Okay?
So just to review, the very first massage they get, they still need to call you and set it up.
You just need to text me with their name and number. Now, you can do it today. That would be great if everybody would just do it today. Because then I will just go through, set up all your profiles, and then you just call the spa, it's 810-356-4646. If you look online, you'll find that. But just call the spa like you would schedule normally. I think that's good for you too. Call and just schedule and see what that's like. Oh, my number, let me put that can I put that in a group chat here?
Yeah. So the very first massage, Luke, you made the decision to give them the first one?
Yes, because usually so you can tell I'm surprising on that one. We usually would do that for them with a student clinic.
Oh, that's right. Okay.
So
you guys are getting a deal. Good for you, Luke.
Ask you guys, don't do that over Valentine's weekend. We're going to be smashed. So I'm typing in my number right now.
Now, who had the massage from Davison? Who started this? Allison, that was you, right?
It's Shelley.
So what I wanted to, I thought we had told you about the discount at the spa, but I apparently did not. So thank you for jogging my memory on this. So anyhow, okay, so if we got everybody here but Teresa. So Teresa's family had an unexpected accidental death, nephew. They're dealing with all of the unsuspected and whatever it goes on with that. We know, right, Luke? So good thoughts in her direction on what's going on with that. Since we're already recording, that means you have to behave yourself, right? Today was a different schedule because of I wanted to give you the opportunity to be able to watch the inauguration if you wanted to do that. It doesn't happen on a Wednesday very often. I was kind of surprised. That's why it was kind of last minute on all of that. So the intention for today is to review the systems of control, the nervous system, and its divisions, as well as it's gonna, you can't separate them. They overlap into the, it overlaps into the endocrine system because those two are so intertwined. Now, those have not come up, but they should be coming up shortly in your essential science readings. So it's usually ineffective to lecture about the parts of that, and your guest speaker videos on YouTube that go with that chapter. I've got those delineated for you. Gives you a lot of different voice, a lot of different presentation for those. You should know how to use those by now. And so what I want to do is give you an actual experience of having to understand that language and those concepts and when you're going to encounter it. And I also want to reinforce how you read a critical, you use critical thinking to read a research paper. And so my intent was for us to kind of go through that initial part, and then I just thought, oh, I'm just going to let them review the paper, and we'll talk about it as a unit here. So anybody got any questions or comments on everything? Good, 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 good. Okay, let me share my screen. And let's go right to these papers. All right, so I picked these out because I'm gonna have to wear my glasses. A couple of things that I did when I picked these out is I obviously was looking for language that would reflect the importance of understanding nervous system. And I also wanted them to be pretty current. So this first one is from 2020. And it is specific about a critical thinking process or clinical reasoning. I thought that was pretty interesting when I came across that. The next one was done in 2019, and this one is a narrative, which is not experimental design. It's more of a literature search and then a comment on how it is relevant. And the interesting thing with this one is it's from Tiffany Field. Tiffany Field was the very first researcher back in the 90s that really started to focus on massage therapy. She's down in Florida. She's at the Touch Research Institute. And so I thought it was kind of nice to be able to bring her into our fold here a little bit. Then the bottom one intrigued me here, this last one. There's actually some problems with this study. And I didn't, there's some parts of it that are really, really good. And there's some other parts of it that, at least in my opinion, I think are not. And so I thought it would be a good one for us to kind of take a look at with that. So the homework then, or the preparation for this, was to look through the study, then flip through chapter 5 in fundamentals, which is the all about research chapter, and then essential sciences 4 and 5. But there are also some indications of hormone interaction in this whole thing. So that would be chapter 6. Try to see how this little exercise here was for you to go, okay, all right, they talked about a dopamine response. Where is that in the book? That's what I was after with you finding the page numbers and stuff. that was the intent there. So let's look at this first study. Hopefully this is just going to take us to it. All right, can you all see that? Okay, good. So when we're looking at a research study, we want to take a look at, you know, when it was done, who published it. I thought this was interesting because it's related to public health. And if somebody were going to get a PhD in something, you know, it related to massage, this is the one I direct them towards, PhD in public health. You can get your bachelor's degree through taking the board certification exam, which is over and above licensure, and then credit transfer into Siena Heights, and then go for that's what Luke did. And he can talk to you about it later on in the program. That call I took and stepped away from is one of my advanced practitioner students. And she just took the board certification exam. And I wanted to get a little bit of a feel on what the questions and stuff were like on that. So I really need to talk to her more, but she passed it. And so that was, you know, encouraging for me. Then you get an idea of who your authors are. And this one happens to be a free full text article. So that's always nice. Sometimes I just get stuck on having to deal with abstracts, which is a good place to start. And that's what I posted for you. So that's what this is here. And the abstract is kind of a cliff notes of what the whole article was about. It gives you just the barest bones amount of information so that you can understand what's going on. And you read the abstract first. That should give you a pretty good idea when you're doing a literature search if this information is going to be relevant to you. So whenever you see keyword list, this is other terms that you could put into a search program and see if you could expand what's going on. Also, pay attention on the other side over here where there are similar articles. You can expand your look into that. Then your recent activity will show up. So anyway, there are features within PubMed that help. They're right at hand for you to look deeper into a topic. So then you have your introduction, and your introduction should give you, have you ever done a research? All of you have had to do a research paper, at least in high school, right? Well, the introduction is a lot like that. It's the literature research part of it. What's already known about this topic. And so as we look through this, we're talking about headaches, which is a real common complaint. And lots of times very difficult to treat. Massage is beneficial. That you can adapt massage to meet that goal of pain management and functional mobility, and you can be fairly effective in at least helping people with headache. But not all headaches are the same headache. So there's that talks about that in here. Now, in the nervous system chapter, in the pathology, one of the main pathologies we have is headache. Who found that? Just kind of raise your hand or holler up or whatever on that. Okay, so right there would be your first connection to here's how the textbook is preparing you to look through this. And it talks about the two main types of headaches, primary and secondary. And primary headache is it's a headache that you have because that's the cause. You hit your head or your neck is stiff or something like that. Secondary headache is a headache like you get when you have the flu. All right, so headache can either be the thing or it can be a symptom of the thing. Headaches are one of those conditions that show up and are part of a lot of people's pathological and stress-related experiences. And they can be acute or chronic, and you don't want to just write it off. You don't want to go, headache. Everybody gets headaches, because it is an early system of stroke. It's an early system or a early symptom of obstruction in, like some sort of a tumor growth or something like that. It's oftentimes a first symptom with an infection of some type. So it's a headache is something that should be seen as one of those general categories. I really need to pay attention to this because it could be something bigger than just a headache. So when we are screening for headaches and doing our assessment, one of the first things we're looking for is safety and potential for referral. So if somebody came in, they said they had a headache, I would say, have you had it diagnosed? Have you had anybody ever look at it? Is this the same type of headache you've had over and over and over? Is this a brand new type headache? Those are always a little bit more concerning than one that is familiar. Is this the worst headache you ever had? That is a big, red flag that bad things could be happening. So it talks about here as migraine, which is more of a fluid issue, a blood flow issue. Tension type, which feels like, it's soft tissue and it feels like you've got a cap that's on too tight, And then you've got the cervical, where is it? The tension type headaches can also be related to, I'll find the word here as I go down through this, neck issues. It's more along that sort of thing. So there it is right there. Cervicogenic. So there's our medical terminology, right? Okay. And then it goes on to talk about how in the medical literature, headache is classified. So you can learn a lot about headache over and above what's in the textbook on this, just by reading this paper. And it talks about how headache is managed with pharmacological and non-pharmacological interventions. And so we're in the non-pharmacological arena. That doesn't mean we don't need to know what medication is used to treat the various headaches. Where's one of the easiest places to find the list of medications? Medline.
Plus.
Very good. Okay. And you want to know what it's used for. And then if you're starting to consider, well, how is massage going to interface with this? You look at the side effects. And that will give you an idea of, okay, this person might be sick to their stomach. I might want to be careful about blah, blah, blah. Or this medication might make them dizzy. I need to be careful about how fast I move them up and down. Those kinds of things. This one might make them bruise a little easier. So now I start to get my own little brain issues kick in when they start using the abbreviations here. So I have to keep, usually they tell you what those are in the very beginning. So TTH is your tension type headache, and CEH is your cervicogenic headache. And I will, bless my little dyslexic brain, I will forget that about halfway through this paper. So if you struggle with that, you're not alone. As we scan through this, I want to get to where all right, so I'm going to read this paragraph to you. Scientific evidence of non-pharmaceutical intervention is highly heterogeneous, and several systematic reviews have been conducted with contradictory results. So there you go. Maybe, maybe not, depends on the study. For instance, systematic reviews conducted by Schlaby et al. Concluded that, one, the efficacy of physical therapy seems to be similar to the efficacy means it works, of tricyclic antidepressants at midterm in chronic headaches. Then what's nice here, if I hover over this, it gives me the article right there. Okay, so physical therapy, which is, we don't know what they're doing in physical therapy, but it is similar to an antidepressant, which would show up, tricyclic antidepressants showed up in the nervous system chapter under medications that affect the nervous system. Multimodal means lots of different things, approaches, including manual therapy. Whenever you read that, you consider massage as a form of manual therapy, and relaxation can be equally effective as propranolol and propionate in the prophylactic treatment of migraine. So there's a lot of big words right there. These two are medications, and prophylactic means you take it so that you don't get it. So manual therapy, relaxation, and this classification of medication are helpful in preventing headache. So we can use this as a way of encouraging people that have headaches, mostly of the tension type or the neck related, are getting regular massage interaction and not just when the headache comes in. Now, I'm not quite sure of my definition here, so I'm going to copy that. Come up here to my dashboard, stick it in there. Yep, I was right. Okay, good for me. So we'll get out of that. All right, we're back to the paper. Somebody nod their head at me. Yep, okay. And it's also indicated, the same kind of thing is indicated for migraines, which these vascular based headaches are one of the hardest to treat. They're just really rough. The results from a more recent meta-analysis, should have noticed these types of studies when you review chapter 5 and fundamentals, have had different results. This author concluded that multimodal manual therapy interventions were actually more effective than pharmacological medication for reducing the frequency, intensity, and duration of headaches in the short term, but not necessarily the long term. So you can't have a massage once to prevent your headache. It's got to be this prophylactic. It's got to be regular. But good research to show that manual therapies of multiple types are beneficial there. You do need to make sure you know what kind of headache you're working with. And that's where a referral can come in. And that doesn't mean that a person who typically has the tension type headache can't also get a migraine headache, or they can't have them both at the same time, kind of a thing. Finally, a recent meta-analysis has concluded that manual therapies are effective for increasing health-related quality of life. So maybe it didn't take away the headache or reduce the frequency, but the person did better. And that's a good thing to know. And if I wanted to keep that, who did that? It's not this. Yeah, it's this one right here. And that's what's 2019. So that's pretty recent. So if you wanted to start to think, am I going to specialize with headache? Maybe start collecting some of these in a file, so that if you wanted to write a justification paper about headache, you could do that. This evidence supports the effectiveness of non-pharmacological manual therapy interventions for treatment of headache. However, these assumptions should be considered with caution. And that is because all of the manual therapies, the studies have, they're hard to do. It's hard to get a placebo on them. They don't always use the same research methodology. And so if you were going to choose a group of studies that were probably more accurate than others related to manual therapies, look to physical therapy right now. Sports medicine is also doing a pretty good job on it, and massage is getting much better. And then it talks here, chronic headaches and non-pharmacological interventions require a little bit different approaches. So just like chronic and acute. So here's where the critical thinking comes in. There's enough evidence to show that massage as a form of manual therapy can be an important part of helping somebody that have ongoing headache issues. We also have to realize that there are some things that work better than others, and that we can't look up a definition. We can't look up a recipe here. I just did an interview about critical thinking on Monday, and they asked me what my definition of critical thinking. And I said, well, it starts with a good question, and then collecting of data, and whether it's history form or physical assessment or research or what, reading about what the stuff is. And then I said it gets really messy after that, because you're heading into a non-black and white arena when you're dealing with critical thinking. There may be a few wrong ways, and there might be a couple better than other ways, but there really is no right or wrong per se when you get into this. So it makes it hard, and it makes it hard to teach. So proper management of chronic pain syndromes, and pain is a central nervous system experience. So there's your nervous system connection, that may have what are called drivers, or may have its start in the peripheral nervous system. And that can be either in the somatic part of it and or the autonomic. So there's a whole bunch of nervous system information that would need to be in place for you to understand this. Science is suggesting that multiple methods are used that are individualized, that include passive, that's massage, it's done for you, and or active, that's like a meditation or exercise, including active listening, empathy, and psychosocial issues. So that's the biopsychosocial model. Some of you are really, some of you characters are really interested in the body-mind connection. We also have health messaging that's involved with this. If a person can manage their condition without using medication, they're going to do better. Because no matter how good the medication is, there are always side effects, especially with long-term use. So here's a word, nociceptive pain mechanisms. That's a nervous system concept. There are sensory nerves that are nociceptive. They're free nerve endings. And they pick up acute pain really good. Like I cut my finger this morning washing dishes. And I felt it. Nociception picks that up. That's what it's supposed to do. Signals harm. Well, good job. But nociceptive pain receptors are not necessarily what is involved with chronic pain. There's something else that happens. There is evidence supporting the presence of altered nociceptive pain processing, both with tension type headache and migraine. And key indicators of central sensitization, including the presence of widespread hyperalgesia, allodonia, and absence of conditioned pain modulation and sleep disturbances. Who found, somebody wave your hand around or something, who found any of these words when you were looking at the either chapter 4 or chapter 5 in the science book? Anybody find these words? The other place they would show up is in chapter 2 in your science book. So anybody know what hyperalgesia means? Just unmute yourself and blurt it out.
That you're hypersensitive.
Right. You know what allodynia is?
That you're not sensitive at all. Like you don't have any feeling.
No,
No.
it makes sense, wouldn't it? It means that you're interpreting a typically non-painful sensation as painful, is what it means. So, you know, you know how the tag in the back of your shirt can drive you crazy? Well, for some people, that is a pain response, and as opposed to a itch or a pick response. Jules, where you at? She down there? Jules? Woohoo, Jules.
Yes.
Okay. Your little man that has is on the autism spectrum.
Yes.
Is he sensitive to tags and all that kind of stuff in his clothes?
Yes, he is very hypersensitive to, well, he has sensory processing disorder as well.
So have they used the word allodonia with him?
They have not. They kind of usually just put it into the sorry. What is my okay. They just call it the sensory processing disorder.
All right.
But that I doing some of the research on my own, I've seen that word before, and he's that way with tags, little things like he doesn't like his sweatshirt pulled up on his arm because it puts pressure on his forearm, and he only likes certain kinds of cotton t-shirts, so we've got to be really careful about what we buy for him.
So here's a definition. a condition where pain is caused by a stimulus that does not normally elicit pain. Now, does he actually call that out as it hurts?
Well, like pants that cuff at the bottom, if they come up onto his calf, he does say that that physically hurts.
All right. Okay. So that's a kind of an example that at least one of you are living with on this. So now just the thought of putting a bra on, I don't even have to do it. Just the thought of it gives me hyperalgesia and a all right.
Actually, my child with type 1 diabetes has that because we have to be careful of where we do her injections because she gets, I mean, it is a pain response, but it's a lot more intensified in certain areas than others.
So this is where central sensitization initiated by long-lasting prolonged peripheral noxious inputs, a shot, an injection, peripheral sensitization. So what happens is that it's almost like a conditioned response. You know, you've got this, we'll use the diabetic thing here. Every day or frequently, there is a needle. They're trying to get past that, but there is one that doesn't feel good during the injection process. The peripheral nervous system becomes hypersensitive to that, which as it sends messages to the central nervous system, says, this is just getting more and more dangerous. It's just, you know, it's the same sensation, but because it's there, there's the, you know, it's frequent, there's anticipation for it. It's, you know, you start to get emotional around it, all of that. There's this crosstalk between the peripheral nervous system and the central nervous system. Over time, what can happen is even if this stimulus diminishes or goes away, we'll use the thing with the shots still. If you brush across that area, there'll be a big, huge pain response to it, not because of the peripheral sensation, but because of the central sensitization. And this is where chronic pain lives, is in central sensitization of the nervous system. The nervous system, the central nervous system changes. It physically changes in response to this. Once central sensitization has been established, only minimal nociception is required to maintain that state. It's really hard to extinguish. So, clinical management of headache patients needs to extend beyond tissue-based impairment, which is considered a bottom up. Let's talk to the nervous system up. That's, you don't not do that, but it's not as, it doesn't stand alone. You still do the massage, but there also needs to be intervention by someone that begins to bring the conditioned response in the central nervous system down. Now that's where exercise and things like yoga and meditation and cognitive behavioral therapy and those sorts of things come into play. I think that's basically what I said in this. Okay, those of you that read through this to this point here, give me some of your understanding or feedback on what you gleaned in relation to I really do need to understand the nervous system in order for me to understand how massage works and why it can be beneficial. Did anybody have any interesting comments to bring into this one, this discussion?
Well, I guess when you brought up CBT, a lot of this does mimic, like, you have to treat the underlying issue if you're getting headaches from stuff that's brought on by tension or stress or stuff like that. Like, you have to be able to treat what's treating your stress versus just going for your physical intervention. Otherwise, it's just gonna re-tense up if you don't treat that underlying issue.
And there's value to that. I mean, it works in the short term.
Mm-hmm.
And I've had clients that aren't going to address the other issues, but they do better if they get frequent massage. That may not be ideal, but it's better than nothing, the short
Right.
benefits. However, this makes us understand, I mean, in the nervous system, in those 2 chapters, is all of the cognitive stuff and the what the various parts of the brain do and our attentional areas, all that information is in that chapter.
Mm-hmm.
And so sometimes people don't appreciate the simplicity that can feel complex because they don't have a background on how things work. There's a part of your brain called the reticular activating system. It is the piece that's on alert all the time.
Yeah, so people with like trauma situations, it's probably still firing if even after they're outside of that.
So sleep disturbances become a big deal. New mothers or parents, let's not be gender biased here, infant caregivers, the reticular activating system is kicked up onto high so that they can hear the baby cry. Otherwise, the sleep paralysis would kick in. And those 2 parts of the brain work to control each other. And it's not beneficial for the infant to not be able to wake the parent up.
Right. But I mean, I guess also with like the sleep paralysis, it's the parent might be awake but unable to
move.
All
right. So there is something to be said for knowing what those cognitive functions and those other lying attentional functions are in the brain. You know, I can remember, I didn't do it so much with Luke, but I remember with my oldest son, Greg, because you just never knew what he was going to do. And so I always was able to relax a little bit better when I heard him. I could go to sleep when I heard him come into the door. Prior to that, I might doze or back and forth a little bit, but not a restorative type sleep until a part of my brain heard him come in the door. So anybody else have any ahas or something that came up when they were just to this part of the paper? Are you convinced you need to know about the nervous system yet? Okay. So this just talks about the various models and the importance of, oh, here we go. The effects of placebo should not be ignored in any therapeutic intervention since it's associated with activation of the prefrontal and anterior cingulate cortex, the thalamus, insula, amygdala, and somebody say that one. Anyway, this one.
Paraquadical?
Gail, can you pronounce it?
Where did it go? Paraaqueductal.
That was pretty good.
Paraquadical.
Gray neurons of all pain mechanisms also involved in non-specific effective manual therapy. This right here, prefrontal cortex, anterior cingulate, cortex, thalamus, insula, amygdala, and probably this right here are all on the radar when somebody has attentional disorder. Anybody got an attentional disorder either in themselves and somebody else and heard these terms related to your own diagnosis?
What kind of disorder did you say?
Attentional, like
Oh,
ADHD.
attentional. Okay.
I've
And
had attentional.
He looks like he's
there she is. Jules is attentional. Not Jules.
Yes, Jules.
Yeah, Jules too. So anyway, the stimulant medications interface here, and that's why they can help in some situations to coordinate a more appropriate response of these areas. And each of these has hormonal interface too, as well as neurotransmitter. So here's the more of the literature search. These are all the terms they used. They did they made a decision on what they were going to include and not include. They mapped their data, and then they came up with scientific evidence for joint-based interventions. So that's your cervical genic, your neck area. And then they looked at soft tissue-based interventions, which is what we do. So we look at strategies that target muscle and fascial tissues, and we do including pressure interventions, massage, stroking, stretching, myofascial release, all these different names. The aim is to decrease muscle tension by providing proper proprioceptive inputs into the nervous system. So we touch a muscle, but we're trying to talk to the nervous system. So can anybody define proprioceptive? Does anybody want to take a hit at that?
It's like the pressure that you feel on, like, let's say your fingers when you touch something, isn't it?
Yes. So let's have, Michaela, you're right in my face on my list of people right here. Have you got a device that you can do a search on with and look up proprioceptive, or are you on the device?
Yeah, I was about to look it up right now before you said something, actually.
All right. And then the next category here has to do with needling. And you want to know this stuff because you might refer to it. You might refer somebody to it. I might refer somebody to a physical therapist that needles, or I might refer somebody to an acupuncturist because they might have a better, an individual's body might respond better to that.
You want me to give you the definition?
Yes, Mikhail.
It says that it's relating to stimuli that are produced and perceived within an organism, especially those connected with the position and movement of the body.
All right. So these little nervous system, we got a bunch of receptors. We got spindle cell and Golgi tendon organs and joint mechanoreceptors. And then we have all of the stuff in our inner ear, our vestibular mechanism, huge interface. Remember how when we were looking at muscle energy technique, I said you can look down, you can look up, you can left, right? That's all related to your inner ear and your eye proprioception through the vestibular mechanism. Guess what? Talked about in the nervous system chapter, part of the peripheral nervous system. We talk to these receptors by pressing on tissue and changing the shape of the tissue and so forth. So here's some evidence for exercise. And then these are your cognitive interventions. This is cognitive behavioral therapies works pretty good. So this is nice. Here's a little table that kind of shows you what works. We're over here on the soft tissue intervention area. And for sure, tension type headache, pretty sure for migraine, questionable for the joint area in the cervical area in the neck. But we're as good as any of the other ones. Exercise is good. So here's the critical thinking part. First, we have to know what type of headache we're dealing with or what combination of headache we're dealing with. Massage in and of itself does the most for tension type headaches. And fortunately, that's the most common. So, and then if we scan through here, so if we're gonna go, okay, this person has headache and they've been told that it's primarily a tension type headache, is there a potential for massage to be able to help that? That's our question as we start our critical thinking. Then I gotta go learn about tension type headache and all of that. And then I also have to think about the structures that might be involved with it. Is it muscle tension? Is it fascia? Is it both? Are they pinching on the nerves? Is the person wearing a hat that's too tight? All of those kinds of things come into play. And then I have to stop and go, will this person come to massage often enough so the interventions that we would use, which would be pushing and pulling to kind of alter the sensation. So a big reason why massage works is that we provide alternative sensory stimulation, which is all nervous system. So we touch, it's hot, it's cold, sometimes it hurts good, it has a pulley sensation. All these sensations stimulate different kinds of sensory receptors. We move the joints around, that gets the mechanoreceptors in the joint. And again, all of this is described primarily in the peripheral nervous system. This language, these terms. So here's the following conclusion. This literature review summarizes most updated data on non-pharmacological treatment for patients with tension type headache, migraine, or cervical genic headache. And the underlying clinical reasoning explaining discrepancies in their therapeutic effects. Several non-pharmacological interventions have shown positive effects for the management of these headaches, but their clinical relevance was small and the duration of effect was mainly in the short term. Well, that's all right, as long, and that'll work with a treatment plan as long as they frequently get massage. Additionally, not all patients will benefit from the same intervention. And it's important to identify these subgroups. And this is when we would refer. Somebody might really potentially benefit from acupuncture, but they're scared of the procedure. So they may end up doing better with massage. On the other hand, we've tried massage the pain symptom feels really, really deep, maybe dry needling would be better at that. So there was a lot of need to understand the nervous system to be able to appreciate and use the information in this article. Now, as far as research is concerned, here are all the references that they used. And it's beneficial. It's really nice now because they put the links in there. And all you have to do is click on them, and it'll take you to that paper. So I'm going to stop share. Okay. Now be honest, this isn't going to work. How many of you did take a time to flip through the nervous system and look at some of the words? Okay, Abby, I saw your hand first. So you're on the, so take yourself off of mute, Abby.
Sure.
How well did you understand that paper?
I had to stop and really look up quite a few of the words.
That's exactly what you do. Very good. And did you see that, I'm going to say a majority or most of the background information related to the nervous system is included in your science book?
Mm-hmm.
So did you look in your science book, or did you look on, did you do a Google thing like I did with proprioceptor or whatever? How did you look words up?
Well, when it came to concepts of the central nervous system and the peripheral nervous systems, I went back to my book so I could understand all of it through your words and through our general kind of basis of it. But with other words, I had specific words I quickly Googled so I could understand just that, that part of the paragraph in that sentence. So
was there any one concept that you can think of that you found in the paper and looked in the textbook, and that helped you have a much better understanding of what that paper was about? Can you think of one topic that you looked up?
I can't think of specifically from the paper, but I definitely went into a deep kind of nosedive from thinking of how our manual therapy and touch produces those happy chemicals. And I went into a big dive of understanding neurotransmitters and how how impulses turn into chemicals and how those produce those kind of emotions and behavioral states and stuff. And so that I went into a ton of YouTube and really started digging into that. So it got me really kind of excited.
Boy, it is exciting too, and they're learning more and more about that.
Yeah.
Who else went to the textbook to try to help themselves study that or understand that paper? Okay, Celine, what can you give us a topic that you looked up?
Well, I guess a lot of it was part of the stuff that I read was the difference between the vascular and the tension headaches, because you guys do have a pretty good description within chapter 4 of Essential Sciences about the difference between them, and other things that you look for with the vascular. It talks about your sinuses. So we also talk about I know that was it a couple weeks ago we read an article about like the sinuses, and like we watched you do like a facial
Yeah,
massage.
we didn't really look at an article, but it was when we were looking at the facial massage thing, and I said, maybe, maybe not, but any kind
Yeah,
of sensation is going to help in there.
yeah, because in the bottom it says,
Head and neck. It's so rich. I
Mhm.
know, Gail, that you're real interested in cranial sacral therapies, and the research is all over the place on that. But just that rhythmic, attentive holding in there, because of all of the sensory, as well as the vestibular and the eye stuff. It's just a rich place to touch. You know, a lot of it does a lot just because there's a lot of sensation in the area. Same with the foot.
well, and I've also been needled before by a physical therapist. So I've been dry needled by a couple different PTs and kind of felt that sensation as well. Because I know that in that article, it does talk a little bit about dry needling and headaches. And I have had my occipitals needled and experienced that as well. So it was kind of interesting to know a little bit and have been like needled in that way.
Yeah, that's a good example of muscles that are just so deep. We can get to them, you know, but if there's just one of those little dudes, you know, that is problematic, sometimes a needle can put a sensation in it that causes it to reset better than some of our clumsier or bigger pressure. Anybody else want to chime in? Yes, Leah. Love the face, Leah. Gotta unmute yourself, Lovey. She's working on it. Well, you keep working on it and we'll come back. Anybody else have something that the textbook helped them understand? Geraldine.
I actually took the time to rewrite it's just one of the blocks that you had in Essential Sciences chapter 4. And it just kind of was something that I thought that I need to just write and read and write and read and say over and over again, because it was so good when it just said, you know, as a massage therapist, when you give a massage, you communicate with the sensory neurons, the receptors, you know, no matter how quickly, slowly, or deeply the massage, blah, blah, blah. It's just like so good that I was like, I just need to like read this over and over again, because it makes sense for how we apply it. And then but the last part of it, some sort of adverse outcome, was like, oh, okay, so that's why we have to keep continuing to learn more to avoid that part of it. So
what's an adverse?
but the stop, contracting, and relax, and the releasing chemicals, you know, increasing circulation. There's a lot of things that are happening, but
yeah, what's an adverse outcome?
I would say the most common one that I know is you get a massage and you don't hydrate enough afterwards, and then you end up not feeling well because you didn't flush out the toxins. So then people
it's
think
not,
that the massage wasn't beneficial, even though it was. They just didn't.
so the hydration didn't flush out the toxins. What the hydration does is allows for proper electrolyte interface. Okay, so if you're dehydrated, stimulation, which is what we do, sensory stimulation, is going to have effects that we're not necessarily happy about, which could be a headache the next day or whatever. So, well, very good. That is excellent. And before I get to Leah, I see she unmuted herself. A lot of people think that massage works because of muscles. Most of the benefit we have related to massage is through the nervous system, and then how it interacts with the endocrine system. So that doesn't mean you don't know your muscles. But Leah.
Right. So sorry about that. So I looked at chapter 5 in fundamentals actually.
Yeah.
Found like it's a chart, it's on page 202. If anybody wants to look it up, they don't have to, but it breaks down like the central nervous system, like the brain, the cranial nerves, and automatic, and I'm not gonna pronounce that word, involuntary
Autonomic.
nerves, and somatic motor motor nerves, and then sensory nerves, and then the spinal cord. It connects them all in a graph. So when they were talking about like secondary headaches, I wrote a long section about that, so I won't read it. But when it talks about that, I immediately went like and looked back at that graph, because that actually, for some reason, that like helped me when I think of tension. I think of like cranial nerves and stuff, and like getting tension like back here, probably because I have my own tension in my spinal cord and stuff. When I get a massage, that's where I usually prefer to get focused on when I used to go. But
You used a word. You used a term, cranial nerves.
oh yeah.
Nerves are where nerves are exiting out of the cranial body base, the skull, into the peripheral. So it's where they transfer from central nervous system to peripheral nervous system. One of the biggies that they are thinking massage interfaces with is the vagus nerve and vagal tone. And that kicks right into another part of the autonomic nervous system called the enteric nervous system, which has to do with your gut flora and your bionome and how the gut brain axis and how various hormones and neurotransmitters live in our gut and are produced by the bacteria and all that kind of stuff. So there's another little nervous system connection in there. Is your foot in the screen, Geraldine? Now your face
Yeah,
is.
I had a pretty serious injury last night.
What did you do?
I was instructing dance, and when I stepped down from a turn on one foot down into the next turn, I overextended and popped one of the muscles in my calf. I'm not sure if it's the soleus or the gastrocentesis, or I said that wrong, I think, but I'm going to my PCP tomorrow to try to find out more. I don't have bone cancer, so I found that out in the ER. They didn't wanted to make sure that my bone was good, so they took an x-ray and bone's fine. I can't stand on my foot at all.
Stand on it at all?
No, I'm crutch bound or crawling around the house, and it's just so sensitive because those muscles are just kind of like going like this right now. And I'm just praying that there's still some sort of a good connection in there somewhere all through. So I'm on a lot of ibuprofen. They gave me a shot in my butt last night, but it's painful even to just sit sometimes, and any movement of those muscles yeah. So it's one big ball right now. It's gross.
So let's use that. Let's use your misfortune here a little bit. Bless your heart. Your body is processing a trauma, an injury. And one of the important things that happens with a soft tissue injury is that it stays still. And that is so that whatever was separated in there stays as close together as possible, because those ends have to re-knit themselves. They have to regrow back together. So is your calf swollen?
Mm-hmm.
All right.
Yeah.
Can you dorsiflex and plantar flex?
Minimally, and it hurts, but it's getting a little bit better. But I'm trying not to do too much of it because I know I need to baby it right now. But yes, I can. Not as much as I mean, I'm probably maybe 10% of movement right now.
All right. So if you can dorsiflex and plantar flex, even just a little bit, You probably did not, okay. So a lot of that's happening in your toes.
Yes. I'm not doing much because the pain is actually going down into my plantar fascia.
All right, so if you can move, this is exactly how I would fiddle with something if somebody hobbled in. And believe me, I've had that. There we go.
It's gonna look gross because it's been compressed with a wrap, but
Let's see what color it is. See how much blood there is in there.
oh. Yeah.
Oh, it's definitely discolored. Let's see the others. Can you give us the other side? I mean, this is for our benefit. It has nothing to do with you. That's what you, honey. We need the medial side.
But if she's saying it should, if you can plantar and dorsiflex, you might have heard what's called a Thompson test, where it's this checking if the Achilles is fully torn, and you probably, if you can at least move it back and forth a little, or okay, but you won't know until they do a full assessment.
Right. Well, I'm hoping and praying it's not the Achilles. Right here does not hurt to palpitate.
Yeah.
Oh,
But
okay.
as soon as I get up to here,
Okay.
it's very, very painful up here. The bruise here and down here doesn't really make sense because this is where the pop came from. Was right
Yeah,
here.
no, it makes perfect sense to me. I think what you did was popped a little tiny residual muscle called plantaris.
Okay.
It's a small one that some people don't even have. So Luke, have you got a textbook handy where you can find a picture of that little dude? It's not the popliteus, it's the plantaris.
I know, yeah. Popliteus just behind the knee.
Yep. This is a little small one where the belly of the muscle is right where you pointed, and that's got a big long tendon down to the bottom of your foot.
So
And
you can see, I'll hold it up a little bit here, but this is looking at your textbook. This is an old edition, so it's not perfect. Here's popliteus, that one just behind the knee. Okay, but we're looking for plantaris. That's tibialis posterior, where might be deeper. There it is. So
okay.
this feeds in very nearby with the gastroc. I'm getting it. There we go.
Oh, wow. Okay.
So there's plantaris, then there's soleus, and then gastrocnemius. And that would be the layer order in reverse. Gastroc superficial, then soleus next, then plantaris next. Then underneath of those are like tibialis posterior and the muscles of the toes, the flexor, the hallucis, flexor digitorum. So it's a crowded space.
Yeah, I would say you're right on for what I'm feeling. Where I felt it, I would say that's right on. That muscle was never even brought up by the doctor or the nurse. They were just going back and forth between soleus or the gastro.
The treatment for what it would be if it was the treatment for soleus versus this in the traditional sense would be very similar. It's a lot of probably, as long as nothing's brutally torn, if they're going to do an imaging or what have you, that's usually, you know, booting you up until you can bear weight, and then you go through, then you start reintroducing movement patterns. These days, the suggestion is as soon as you can bear weight safely, to challenge it and to do movement. So, but
Yeah.
listen to them and follow the protocol. And it's interesting how these things get graded. And let's say just from a traditional sense of an ankle sprain, the way they grade a grade 3 is you can't stand on it. Where you can grade a grade 2, you can stand on it, but it hurts and it makes you limp real bad. And a grade 1 is you can stand on it, but when you walk, it hurts some, but it doesn't disrupt your gait as much. That's kind of the generalized way they assess this stuff. So, It's,
I would be fairly
but
confident that it's that plantaris, and it's usually not identified. They'll usually identify it as some sort of soleus gastroc thing. Uh, just like Luke said, the treatment is the same. They're treating the posterior compartment as a strain, but the pain is like a deep. It's deep, you know, and you can't really find it more surface wise, and so
for your self-care,
it's not as serious an injury
right?
if it were soleus or gastroc, but it can be a naggy one.
The ACE bandage is an excellent. If you get access to some of the, doesn't matter what brand, some of the KT tape stuff,
Yeah.
just you don't have to make it pretty. Just stick it all over the lower leg. That'll act as a little bit of a manual lymph drainer to help move some of the residual fluid and swelling out of there. Doesn't fix anything, but it should take some pressure off the little nociceptors and help with the swelling. So
yeah. So that doesn't matter really how I apply it. Do I apply it?
just all over.
Okay.
Yeah, crisscross it, put it all over the place. It moves the skin. And it acts as a sensory sensation where you feel the tape. And when it's okay to move it, and they usually want you to introduce movement pretty quick. But once that is in play, it kind of acts as a little bit of a distractor.
Mhm.
So, thank you very much for your injury, Geraldine.
I'm just hoping it's not 8 weeks because I can't handle 8 weeks of it.
Yeah.
That's really too long.
As long as your gastroc and your soleus are good, you've got stability in there, but that plantaris crosses the knee. So you can get some angsty behind the knee a little bit with that.
Yep.
And so, like I say, your stability will be in place if gastroc and soleus come into play. I say this is a residual muscle. A lot of people, some people don't even have it anymore. But the sensation may stay there. And this is how this can develop into the chronic pain or sensitization. Now you're going to know enough about how all this works, so that's not going to happen to you. So, but, you know, perfect example, and how the proprioceptors are working to keep everything tight and stiff in there so that whatever did tear apart kind of is approximated, and maybe it'll grow back together a little faster.
Hopefully.
So there we go. Interesting. You just never know what's going to happen, do you?
Yeah, my calves were tight. I had done 4 massages over the weekend, and I did like 3.5 hours with like back to back. And they were tight, and I knew I wasn't paying attention to how I was standing, and that's why my calves were tight. And so that was Sunday, Monday, and then Tuesday the injury happened, and I just think they were so tight. And
Yep, and that little sucker is really deep, and
that's
yeah, it's really deep, and you can't stretch it. So, and you're the 4th one that has said that they've been getting in some good hands-on practice. So I'm glad to hear that. So, okay, let's go to the next paper. Time is it? Whoop. Oh, here we are. I'm going to skip over the one that Tiffany Field did. I want you to take accountability and responsibility for reading through that. You kind of got an example now of how important that is, I want to look at this one because there's some issues with this one. Yeah, I keep moving you guys around over here. Okay, so the title on this is Effect of Psychoregulatory Massage Therapy on Pain and Depression in Women with Chronic and/or Somatoform Back Pain. So somebody look up somatoform so that we are sure we know what that word is. So the first thing when I saw this, it was done in 2020. First thing when I saw this is I thought, what is psychoregulatory massage? So one of the problems we have in the massage world is all kinds of unique names for something that aren't really that unique. So I got a red flag on this right away. And as I read through it, I realized that what these researchers had done was took a couple of the main methods we use, stroking in particular, and they slowed it down and decreased the pressure. So what that is modification, right? They just altered the modifiers. So it's not a specific type of massage, it's an adaptation. It's an adaptation to. So if they had titled this, adaptation based on stroke type, speed, and depth of pressure on pain for depression in women with chronic or somatoform back pain, I would have been real happy. And of course, since it's all about me anyway, and whether I'm happy or not, one of the issues we've got ethically is we've got too many weird names out there that nobody knows what it is. Did somebody look up somatoform yet?
I did.
All right, spit it out. Somebody spit it out.
It's a, well, I'm getting a disorder. This right? Somatoform disorder.
I
Well,
also found one
that'll
up.
give us what we need. Somatoform disorder. That'll give us what we need.
It manifests as physical symptoms that suggest illness or injury but cannot be explained fully.
Right. So this used to be called, there's nothing wrong with you, it's all in your head. But it's being manifested physically. So central sensitization has started to come in and better explain this idea of somatoform. So that caught my eye too, because that's kind of an old term. Kind of don't use that term as much. So already I'm biased when I read this paper. As a reader, I'm biased because it has poked some of my triggers. How is that going to affect how I process this paper? Because I'm starting out with it bias. I already have an attitude about it. How's that going to influence me? Somebody just say it.
You're not gonna trust the information as much because you think in your head, well, that's an old term. We don't use that anymore.
Yeah, I'm already got an attitude about this paper, which is going to make me less likely to even believe what's in it. And that's not going to overall do me any good, because that attitude is going to keep me from looking for and finding things that are. So that's the first thing. Okay, so here's our abstract. And I'm not going to read that specifically because we're going to come across it as we go through the body of the paper here. So in the introduction, this is primarily from Germany. And I had to process that a little bit because I don't know if somatoform is more common utilization in Germany. And I'm not as familiar with that. And this psychoregulatory massage therapy, this named style, maybe that is something that's a little bit more unique to that country. So it's helpful sometimes to know where things originate. So neurophysiological evidence indicates that C tactile fibers associated with the oxytocinogenic system, oxytocin, can be activated by slow superficial stroking of the skin in the back, shoulder, neck, and dorsal limb area. Did anybody look up what C tactile fibers are? Or find it in the book? So who hasn't done anything yet? Somebody, who haven't I picked on yet? Look up C tactile fibers, somebody. Alyssa, are you in a situation where you can look up C tactile fibers? Sometimes you're on one device and you can't get to it. So can you do it?
Yeah.
All right. Londa, can you look up this oxytocinogenic? Can you do that, Londa? Oxytocin
Yeah.
Okay, oxytocin is an interesting little thing. It's a hormone and a neurotransmitter. Let me know when you get it.
You rolled up while I was still typing it in.
I'm sorry. See it? OXY. Did you find C tactile fibers yet, Alyssa?
Not really.
Let's see if I can find something.
I've got it.
Was that Michaela? Was that you?
Yeah.
All right.
They're named, they're low threshold nerves because of their exquisite sensitivity to slow, gentle, tactile stimulation.
Okay.
But unresponsiveness to noxious stimuli like pinpricks.
All right. So, whoops. So, did I lose where I was at? I think I did. There we go. So these C fibers, because what they're saying in this paper is that they want light pressure in certain areas of the body that have more of these C tactile fibers in them. And they're going to alter massage to better interface with those. So have you got the oxytocin one yet, Blonda?
Yeah, it said it was misspelled.
Oh, well, that's
And it says it's yeah, okay. Well, it said to check out this one, which is OXYTOCINERGIC. And it says containing or releasing oxytocin.
oxytocin.
It is tocin. Okay, that's what I'm used to, but looking at it spelled. Okay, oxytocin.
All right, now Abby and Abby, are you there, Abby? Abby, you were the one that said you did the deep dive into the neurotransmitters.
Mm-hmm.
What did you learn about oxytocin?
Oxytocin. Those are the like pain relieving hormones. The pain relieving.
They are.
Mhm.
Though you're thinking more of the endorphins, I think.
Oh, mm-hmm.
Doesn't oxytocin relieve pain a little bit? Like it's your kind of uplifter, but also knocks down your pain.
It's the bonding one. It's the one that makes you feel okay when it's stimulated. It's the social connector one. It's the one that's involved in releasing the egg as well as letdown response for lactation and all. It's very interesting. And they are studying it as if you can stimulate this, it should bring down the stress response because it triggers feeling safer. So the premise here is that they see tactile fibers that respond specifically to a certain type of touch, interface or stimulate oxytocin. So that's a cool premise. All right, so what their premise is that, all right, now where'd that go? The Bumgart here that concluded that the effectiveness of massage therapy depends on the design of the parameters. These should look familiar to you: pressure, speed, direction, and rhythm. Don't those look like the modifiers? Studies on the effects of oxytocin and its interactions with the neurophysiological system have provided possible explanation for the effect of touch or massage therapy in chronic pain with or without depression. So that's what you were saying, Celine. So right there, we have got nerve, a specific type of nerve, its receptor style, and an interface with a hormone and that acts as a neurotransmitter. That's a lot of nervous system chapter right there. So then it goes on to say that there's evidence that activation of these C tactile fibers can significantly alleviate muscle pain. But if I'm going to talk to those fibers, I have to use a lighter, pleasurable, rhythmic approach to the massage. So stimulus of a gentle or moderate touch processed in the skin by C tactile fibers is transmitted via ascending spinal thalmalactic pathways to the insular cortex, an area of the limbic system. Those are all brain areas. Anybody know what the limbic system is? Anybody want to just sharp out on that?
Isn't it like part of your fear, where you hold your fear?
It's the emotional centers.
Emotional.
It is. And it's right near the olfactory. A lot of sense, the sense of smell will activate it.
Yeah, and deja vu comes through a sense of smell lots of times. So pretty interesting. Our nose basically turned into our limbic system. So dogs and cats, they have a very rich nose world. We've lost a little bit of that as we are processing things at a little different sensory level through this limbic system. And then we've got these ascending and descending pathways in the spine. They're big roads, they're like expressways. And one of the mechanisms of massage seems to be that we stimulate with a novel sensation the ascending pathways, which then modulate the motor response or our descending spinal pathways. So descending modulation, that is going to change our perception of stiffness and pain. So you'll see that descending modulation is one of the reasons why they think manual therapy works. Okay, so the whole premise of this study is that if you activate those, if you can get those specific fibers activated, that's going to interface with the oxytocin system, which is going to interface with a person's depression and tendency toward or activity around somatoform disorder. They compared it against what they call classical massage therapy. The way they define classical massage therapy, I wasn't particularly happy with. So here was the definitions of the two. The intervention, let's see, I don't want to. The design of the effect parameters differed between the interventions and control groups in terms of pressure, speed, direction, and rhythm, as shown in Table 2. The interventions also differed in respect to the target organ and body areas treated. Their style targets the skin and superficial fascia, and they say classical massage therapy targets all tissue layers, including the periosteum. So that's right. But we also can, through adaptation and modification, we can target skin and superficial fascia. That was another area that I was a little concerned about. When you read this to me, because I was already biased, right? In the beginning, I'm already biased, and I say, well, they're saying that massage can't target that, and I know it can't. So the method they are talking about is unfolds from 3 partial massages to a full body. So they start with warm oil in both supine and prone positions, and they use soft to moderate and tendencies of continuous slow strokes. These slow strokes are uninterrupted throughout the entire session, except changing from supine to prone body position. So you just keep massaging around, it just rolls and rolls. The therapist does not touch the different body parts in separate sequences, but moves in a harmonious transition from limbs to trunk to create a whole body experience. Okay, in contrast, so they did a whole body. In contrast, their comparison, they applied classical massage to the only to the back. So they're not comparing apples and apples. Somebody explain to me why I say that.
They did all the stroking on the whole body, and the other one just applies to the back. Like it doesn't even take in the whole, like look at the whole body.
Yeah, that's not an apples to apples comparison, is it?
No.
All right, so right there, it's flawed. Their design has got a flaw in it, even without me being kind of sniffy about this article. So here's what they say in their kind of table here. The pressure is soft to moderate. And with classical massage, it's soft to strong. I'm okay with that. Speed, continuously decreasing to a speed of 10. Let's see, this is on centimeters. So what I'm talking, I think is that it gets slower and slower and slower as it goes. And connective or classical massage is uses a slow speed and recommended for pain reduction, but it's not clearly defined on what the speed is. And it depends on the training and the individual therapist. Well, yeah, but that doesn't mean that we can't do massage therapy following the same recommendations here. This is not different. It's just an adaptation of this. Direction. The body areas are all connected, and they end with cranial to caudal strokes. That's up from the head down to the feet. And then here, it depends on the massage therapist's training, and the direction is from an origin to the beginning of the muscle. That's not even accurate. That's not even right. From the origin to the beginning. So origins, confusing muscle terminology, origins are usually more proximal, whereas the insertions are more distal. So the origin to the beginning of the muscle, that confuses me. You got any idea what they're talking about, Luke, when they say that?
I'm working on stuff, so I haven't really been.
Oh, okay. Well, that's all right. Anybody else want to chime in? Am I the only one that doesn't understand what
Well,
this
the origin and the beginning of the muscle is the same thing.
Yeah, so
Yeah.
So I don't
is from
understand.
the origin to the beginning.
Unless they're talking about the origin starting at the tendon and going to like the muscle belly.
Yeah, so we got
That
an
could be.
ambiguous statement here.
You don't really know.
Yeah, and then the rhythm is harmonious and constant contact with the patient until the end of the treatment. That's what we strive for, isn't that? Didn't Luke teach you that you had a connected sequence and a transition? So for them to say that a rhythm is not defined, is not presenting an accurate interpretation of classical massage. When I read this, it sounds like they're bringing up all of what they see as the positive points to their adaptation here, and then trying to identify enough differences here so it looks like there's two different types of massage. Now,
is it possible some of this is due to this study was in German and there's a language issue?
That is something that I eventually considered because it was translated. So that stuff does get lost in translation. So we have to keep that in mind.
Which is too bad when it comes to something like this that is supposed to be scientific and more exact, that it gets lost in translation.
Because down here it says the intervention group was treated by 7 therapists who received professional training to standardize the performance of the style, which was applied for 30 to 60 minutes. The control group, now see there's a discrepancy here too. The control group received 20 minutes of classical massage, which was not standardized, but applied individually, reflecting standard care within the German statutory health insurance scheme. So again, we don't have apples to apples here in terms of duration either. So they were treated by the same therapist through the entire study, and each group received 10 treatments overall, which were scheduled twice a week. So then they collected all their data, and they used all kinds of data instruments. So they used activities of daily living, they used disability indexes, they had them take all different kinds of questionnaires related to mood, and that, you know, so and these are all standardized data collection instruments, so that's all good. So then they compared all of that. And then we get down to the discussion part of this. So the primary aim of this study was to examine the effects of 2 forms of massage therapy in patients with chronic back pain. Then again, they listed all of their stuff. And in the group receiving the targeted massage, it said that the decrease in the score was statistically significant, but the group receiving classical massage did not reach any kind of significance, no clinical relevance. This is a little technical for where we're at right now. So it says studies using microneurography have indicated the existence of low threshold, slowly conducting C fibers in superficial skin layers that are predominantly activated by slow and low velocity stroking stimuli, which is what their method is based on. In contrast, stronger pressure stimuli penetrated into deeper subepidermal skin layers, activating rapidly conducting A fibers. A tactile and C tactile afferents these are sensory, which means they're going from the periphery to the central nervous system, are regarded as important for discriminative and effective dimensions of touch perception. Accordingly, atactile fibers are predominantly abundant in the skin of the hands, whereas C tactile fibers are predominantly in the hairy skin of the limbs and back. So that would, if we were going to target these C tactile fibers, that's why they focused on hairy areas. And why they had this different adaptation. Then they talk about it in separate studies. So here's our oxytocin. Studied soft massage like touching through interaction of the oxytocinal genetic system with the opioid system Abby, that's what you were thinking of when you said the pain control ones. With the activation of the periaqueductal gray neurons. And so they found oxytocin receptors in this part of the brain. And when these were stimulated in the descending pathways, central nervous system out to the periphery, there was influence on chronic pain perception. So oxytocin inhibits the conduction of pain in ascending pathways, and it also functions with the opiate system in the control mechanism. Thus, oxytocin can inhibit acute and chronic pain stimuli at different levels of the central nervous system, both ascending and descending. Boy, if you didn't know about the nervous system, that whole thing I just attempted to read to you would go right over your head. How many of you want to admit it went right over your head anyway? Anybody want to admit that? So now they did talk about limitations, which is good, and where the study, and they do call out some of their own areas where they could have been done a better job. So right here, they say the difference in the time and the difference for the whole body, which we had pointed out. So finally, we get to the conclusions. Our results indicate that psychoregulatory massage therapy, which is general massage with adaptation in terms of location, pressure, speed, and rhythm, is more effective than classical massage in reducing pain and depression and enhancing physical capacity and activity in patients suffering from chronic unspecific back pain. Unlike classical massage therapy, psychoregulatory massage therapy characterizes a massage technique by which the therapist applies soft and slow strokes upon the skin of the back, neck, and shoulders and upper arms that specifically activates C-tactile fibers. Future studies should examine the importance of individual differences of comorbidity with depression in patients, blah, blah, blah. And there you go. And then you know what this is all about. Oops. Okay. What are the concerns over and above my bias and attitude with the information as it is reflected in this particular paper?
I had some concerns about the fact that it didn't note whether or not these people were being like psychiatrically like medicated for their depression as well during this. Like, because that can also link to a upswing in mood and feeling a little bit better if they're being co-treated, like getting these psychoregulatory massages as well as a medication, you might see a bigger improvement. Because when I read through there, it even talked about how like one group was completely dismissed because there wasn't a huge difference. It was like the group T1 didn't get a huge, and I had read through it, but
yeah, so there was a lack of some information letting us know what other treatments the people were receiving. So that makes it hard to make decisions. Absolutely. Now, when you do a research paper, you can't write a book, right? And so sometimes, it gets dicey sometimes on what's included in terms of information or not. But your control group and your experimental group should be similar. If you can't have an experimental group that's taking all taking a antidepressant, and then your control group is not also taking an antidepressant, because that's going to skew your results. So good. Anybody else? What if we were going to make some assumptions about the information we found in this paper? Michaela.
I don't like the fact that between the two groups they didn't do like with the timing. The timing was not the same, and the one was a full body, the one was only the back. Like, how can you even properly compare those two groups? They weren't even done the same. Like,
so would you want to expand on the idea that I had, that they were trying to separate this out as this would be the way?
yeah,
And only
definitely.
people trained in that way could
Yeah.
efficiently.
Yeah, I would agree with you. It definitely seemed like they were in favor of the one way and didn't really like the classical, so they were trying to make it seem like the classical wasn't that great and the other way was better, because it seemed like that one was favored.
So I wasn't the only ones biased. Is there a possibility that the authors of the paper were a little biased?
It seemed that way to me. It seemed like the authors had some bias with them. It didn't seem just objective. It seemed like there was biased in there.
So do you think that you have the skills that you could modify? You could take that paper and you could go, well, it's this idea of these C-tactile fibers. That's a good idea. That's good information to know. And they respond best to this type of sensory stimuli. Would you use that information in a resourceful way, somebody, to adapt your massage if you have a client that has depression or somatic, or chronic pain?
I think you could. I think there's good pieces of information in the paper. I think you just need to be careful what you're taking from it. Like, really analyze what you're going to take from it. Like what you said with the C-tactile, that seemed very objective to me. But what seemed subjective was the method of.
Okay.
So there's definitely information in there that you would have to pick and choose from.
Celine?
Well, like earlier in the chapter that has to do with our nervous system, it talks about how when you put a lot of pressure, sometimes you have the muscle contract and it does more harm than good because it's just so tensed. So like that light to moderate pressure is probably something that you can bring into massage with people with chronic pain, because you don't want to overload them if they're already in pain.
So Tiffany Field, the study we didn't have time to look at, her initial research was on preterm infants and massage and their weight gain and how much less time they spent in the hospital. And she found that the pressure had to be moderate, not painful or anything, but it had to be moderate. If it didn't penetrate through the skin, that it actually ended up overstimulating the baby. So the light touch didn't work for her parameters. It had to be the deeper touch. And obviously the intensity is going to be adapted to the size and age of the client. But we talked about that earlier before we were doing anything official about pressure levels, where some people, just because they're a certain size or whatever, doesn't mean that they are going to want heavy pressure or what might interfere with that. Yes, Leah.
I just want to pull a quote from the book. It's not super long, but it like kind of like encompasses this whole thing. It was on chapter 5 in one page 165. I don't know. I didn't put essential science or fundamentals on it, but and it was under a practical application little blurb. So it said the approach to massage that is most apt to achieve these outcomes in a general full body, non-specific, non-painful, pleasurable massage using moderate pressure and moderate drag for 60 minutes is the single most important way to deliver a massage as a massage therapist. So I thought that summed it up pretty good.
It does, except that if we were, moderate pressure, that goes towards Tiffany Field. If I were going to rewrite that again and I did more research on the C-tactile fibers, I might modify that by saying inclusive of both light and moderate, because I can see that there is a particular stimulus, a stimulation that we would use that would be more apt to affect these C-tactile fibers to engage oxytocin. So how about that?
Yeah, I like that it included like a full body though, because
Yes.
that's definitely.
There's something about that full body non-specific massage that's rhythmic, which is what this last paper brought forward.
Right.
Yeah. So, okay, here's your ticket out of class today. Based on these papers that had valuable information across the board, how are you going to go about is absorbing the information in your systems of control unit, which is nervous system and the endocrine system? How did this stimulate your desire to want to read those chapters and really understand them? Michaela, go.
Well, more of my motivation came from the pediatric paper, just because I have a passion for pediatrics and babies. Like when I was doing my nursing clinicals, I wanted to be an OB nurse.
Okay.
So just simply reading through that and getting a couple of aha moments just kind of motivates me more to want to dive deeper, because it's just something closer to my heart. So it makes me more passionate about it.
Very good. Leah.
I particularly enjoyed when I was revisiting like chapter 5, the PICO.
Yes.
I know I wrote it down. I could hardly read my writing. So the patient and the problem, intervention, comparison, and outcome, and just thinking about that in the questions that they had listed in the book. I'm not going to read them right now, but trying to incorporate that into my critical thinking when giving.
Absolutely. Very good. Very good. PICO. It's a way of developing a question and then working your way through to find, some parameters around what you're going to end up doing. Celine.
Well, I really liked the last article, even though it was kind of not the most scientifically sound. I really do like the connection between like depression and healing. So that kind of psychosocial aspect to it. So I really enjoyed that, but it definitely has, I do want to learn more, because there was a big part about like different parts of the brain and how it has an effect on like memory and depression and stuff like that, and how we can affect it ourselves through massage.
Yeah, it's pretty fascinating. How about you, Jules?
Well, like Michaela, I really was interested in the pediatric side, but especially in the neonatal part of it. My second child was a preemie, so it was really interesting for me to read about the neural part of massage with the development of the preterm babies. And that was pretty.
One of the areas with preterm is, of course, there's respiratory issues, but a lot of it has to do with nervous system regulation.
Yes, and
nervous system is not mature enough yet. So,
yes, my daughter was 6 weeks early, so we had to be really careful about too much stimuli and everything. So it's really interesting. That was interesting to me just because it could relate to it could relate to a lot of the information that the nurses gave us about taking her home when she was so tiny.
About you, Wanda? Did we lose Wanda? Is she frozen?
No, I'm not frozen. I just, when you said the name, somebody else's noise went over and I didn't hear what you said. So I didn't know who you called on.
These 3 research papers make you want to just really read those chapters in the textbook.
Well, I don't know if one of those really did it for me, but just in the chapters themselves, reading and making that deeper connection between mind and body, and how the nervous system and the chemicals within the body, react to the massage, and it just connects more dots.
Very good. Abby?
Well, I really found it interesting when you were dissecting like the 3rd article with us, because you were able to translate how they were describing that other type of therapy, the psychoregulatory therapy, versus like what they're describing as classical therapy. And you were able to understand just how the different techniques are and how it's more of an adaptation and stuff. So I think us understanding the fundamentals and reading into our chapters and stuff, where we can be able to down the road read articles like that again, and we'll be able to distinguish that.
Yep, very good. And I'm sloppy, and I can't pronounce all the words, but I can, by looking stuff up, I can make sense of an article like this, and then I can translate it to help somebody else understand it a little bit better. And I can also extrapolate, how's this really going to affect my massage approach or what I teach your students? So I'm really glad that you identified that. How about you, Alyssa?
Yeah, I really like the psychosocial stuff, so.
No, you do.
Yeah.
It's a lot of the overlap between the bio, psycho, and social is the neuroendocrine system.
Mm-hmm.
And how it manifests in our behavior. And so people who have an interest in that actually don't find the nervous system and the endocrine system too tedious. They can start to see relevance and understanding that, even though the names sometimes can be, there's a lot of language, a lot of language there. Good. How about you, Allison? There you are.
Yeah, so my favorite one was actually the Tiffany Fields one, because I didn't realize there was a connect, but I was premature as a baby, and I'm a severe asthmatic, allergy induced. So it was interesting to see that connect. And I'm also, I live the respiratory world. So whenever it comes to learning about the respiratory system, I find it really interesting because that's what I live, So that was my favorite one.
Tiffany Fields, one of my heroes. I've had a chance to meet her once or twice, but she really, back in the late 80s and early 90s, really made, small steps, but changed the trajectory a little bit of how important massage research is. So she's one of those pioneers. Now you switched on me. So Gail?
Well, I just really enjoy looking at the craniosacral system and the nervous system and everything. And I also do visceral manipulation, which goes along with all the organs and like the gut-brain connection and all of that. So I just find it all really, really interesting.
It's cool. It is very cool. Now,
Yeah.
who didn't I get to? Did I get everybody? Well, you guys we're over time. But I want to, this was a really good discussion. And is it okay with all of you if I maybe post this one up on Facebook so people can see how, oh, Geraldine, I didn't ask you. I knew I lost somebody.
Yeah, I'll just be quick. I'll just say that I like the word oxytocin. I really like it, and that it's proven that people touching people makes them feel better. Wraps it all around for why we're doing what we're doing.
Yeah, and you got a boo-boo. So, do I have permission to post this one? Because I think that it's a good example for how you do this. And then, you know, a lot of us as a collective are going through some stuff. Okay, let's just keep everybody in, you know, gentle thoughts as we collectively go through stuff. Okay, and keep Teresa in mind as well. So, well, good job. Thanks for being patient with the overtime on this, and same time next week. All right. Thank you all.